So when we kind of came in here, I know Medicare Advantage is in everybody's forefront. There's a lot of work that's been done on Medicare Advantage. And probably over the last few years, as we continue to transition, this is going to be the year 2025 of what actually happens. Is there a repivot? How's that going to impact ambulance per se? So there's a lot going on, of course, in the hospital space, physician space, things like that. But relatively, I'm going to speak to this from an EMS perspective, and then some things that actually that there's probably some really short-term fixes that could actually happen. It's kind of low-hanging fruit at this point. But there's also some jaded part of me that's it's easy to do, but why didn't we do it? As well that some of us kind of talk about internally. I'm going to kind of walk through some data. I'm actually going to give a plug for Solutions Group right now. Y'all should go to solutionsgroup.com if you really want to know. We're technology, but we have some different verticals that we actually have been working on. We haven't really marketed a lot of what we do in the Rev Clarity arm and the Insight arm, but there's an area that can give you some clarity around your billing practices as well as anything that you might do around it. We're growing fast, lots of different offerings that we give. We're mainly a technology company, but we do help our clients with a lot of different things. And we're not just in the EMS space, just so people realize that. Probably 60% of what we do is in the EMS space, but 40% in the technology space. We do a lot of stuff in the hospital arena, anesthesia lab. So we get a window and a view into certain data that's pretty interesting to me. I'm going to break this down pretty simple. Some people are going to know this, some people just don't really know. So I'm going to actually just tell you what is Medicare Advantage? I get a lot of questions from some people that are moving into it, like on being kind of like a patient advocate. So what actually is it? As we're getting older, my parents are in Medicare. There's things that they're navigating through. They're being bombarded by marketing right now. Like, join Medicare Advantage. Is it the right thing for us? I know most in the EMS sector said stay out of Medicare Advantage, but a lot of times they're doing it from their window because Medicare Advantage really isn't advantageous to the EMS system, but it might be based upon the different clinical capabilities or the different issues that the seniors might be encountering at that point. So let's just kind of walk through it with it. Pretty basic, guys. It's an alternative to Medicare Part B. And think of it like how EMS does privatizes things, whether it's electricity, things like that. So they'll privatize. I liken it to the prison systems. A lot of them are privatized. Same concept here is basically saying we're going to privatize Medicare to private payers to manage. They typically, theoretically, can case manage patients better. That's to be debatable, but that's kind of the thought process around it, is that they generally see things to try to lower those expenses or what have you when you're looking at the Medicare Part B to Medicare Part C. So more of a private payer initiative. Um, Most people say, are we ever going to move into kind of like a one payer system? There's a lot of different things that we do, guys, that kind of start leading us that way. And this push to move Medicare Part B from a governmental oversight into a privatized indicide, if you really think about that, it's really, really kind of more aligned with letting payers kind of work through this. We see this on Medicaid, very rampant in the Medicaid areas with Medicaid managed care. You're managing that. Private payers are doing that. And always know that the top five, when you see some of that kind of stuff as well, they're all publicly traded. Okay, so we start talking about that. They're publicly traded. What does that mean? That means they make margins. Where do those margins go? It goes back into stakeholders, your 401k plans, your pension plans. There is a whole thing that begins to happen. So if you look at the economics of it, you begin to understand it. And this is to the gentleman we were talking about, whatever, is healthcare right? Or is healthcare privilege? Where do you stand on it? What does that look like? And we get into this whole kind of Wall Street. But I call healthcare right now kind of a Wall Street fight what we're seeing. Here's the difference. The main difference is between a Part B plan and a Part C plan when you're looking at it. Your payer under Part B is going to be Medicare or government related. Your Part C is going to be an insurance company. Privatized, mainly it's a privatized insurance company. Your provider choice is you're going to pick those who participate in Medicare. If they don't participate in Medicare, guess what? You got to pay out of pocket. Part C is mainly in network providers that you're going to use unless you're accessing emergency services. Then out of network gets involved, and they usually have to revert back in the EMS space. Most of the time, you're out of network, and so you're mainly going to use basically the Medicare laws are going to apply. There are some caveats to that in the EMS space, but generally speaking, under Part C, you're going to have networks. And I'll go through because you have different types of networks. Your out of pocket is going to be 20% of the Medicare level. We already know that, subject to your deductible. If you are in Part C, that is going to be dependent upon the payer. So that's why sometimes you're thinking, well, they don't have zero out of pocket there. There's a lot of flexibility that Part C plans have around benefits, and we're going to get into that because that is going to be impactful. I'm going to show you how you can access here in Colorado. You can understand what's going on in your neck of the woods, what that looks like, how you can access through that process. Now, coverages, generally speaking, Part B only covers like inpatient, hospice, skilled nursing facility, home health labs. Part C is going to include inpatient, is also going to include all of the benefits associated under Part B, and it's also going to include things like vision, hearing, dental. Sometimes it covers non-emergency transport, like wheelchair cars. It'll cover certain things to doctor's appointments, and they'll give them other different options in that Medicare Part C. They have a lot of flexibility, just like Medicaid managed care sometimes can do these value adds. So does Part C. So this is why it sometimes is very beneficial to someone who's over 65. If they've got certain things happening in their life and they know Part B is not going to cover this, going to be an out-of-pocket expense, it's very beneficial for them to look at a Part C program. So while you may not like it as a ambulance provider, they may need that for certain options that may not be available to them under Part A or Part B. Okay. Here's kind of how the monthly premium works for the Part B. Most people are like, well, how do they come up with the Part B premium? So everybody automatically gets Part A, which is inpatient. So if once you turn 65, you're on Medicare Part A. You automatically get that. So if there's an inpatient hospital stay, you automatically get that. You have to elect for Part B services. Okay, you can do it a few different ways. I can say I'm going to go into care, or I'm going to elect for it. And how much is that going to cost, and what's that going to look like? And if I can't afford it, this is where Medicaid comes in. So why some people have Medicare, Medicaid. But this is how they come up with the premiums right now for it. It's all based upon how you file your tax returns. And that's going to determine for you what you will pay in an out-of-pocket expense monthly for a Part B, for the Part B services, which is going to cover your labs, your physician visits, and things like that from those services as well. And so people wanted to know, well, how much are we going to pay? This is what they're dealing with. Now, what are they dealing with Medicare Part C? That is going to change based upon the Advantage program that they use. Generally speaking, in 2024, the average monthly premium cost for someone to go on a Medicare Advantage program was about $18. Right? It's a lot cheaper than going to Part B. There's different benefits that are associated with them to doing that as well. And so it's very interesting. Some of them have actually zero premium to go into Part C. So it's very incentivized. This is why Medicare says, because, government doesn't manage care. They just basically, it's fee for service. You provide something, somebody pays the bill, they pay the bill. Medicare Part C and insurance companies technically are supposed to be managing the lives. Now, that remains to be seen if they're doing that, but generally speaking, that is what they should be doing as well. Here is how, if you want to access and understand, I want to kind of see the premiums that are going out. Here's what I did, kind of just looked in for the Denver area at this point in time. You go to Medicare.gov. Any patient can do this, any provider can do this, and you can actually start going in there, and I just kind of choose and see what's happening in my area. I'm going to plug my zip code in, and I'm going to just start looking and seeing what plans are offered in this area. There's tons of these plans that are offered in this area. Just picking out a few of them to kind of give you a showing. You see where it says star rating, how you get 5 stars. If you've been reading the news a bit, you've been hearing about all these bonus payments that have been paid out to hospitals and their star ratings are impacted. And if they have a lower star rating, they get less of a bonus. And there's been this whole big contention around it. Several of the health plans sued. This is what it is. The higher the star rating, the better the plan. The lower the star rating, they're not managing the plans correctly. And so most people achieve, most of the insurance carriers want a 4 or 5 star. The moment they get to 3, 2, 1, it's like you don't want to go to a restaurant where you see a C on the restaurant. I want to see an A or whatever. That's the same concept that we have here as well. Now, notice on this, if you were going to choose AR Medicare Advantage, this particular plan, it offers a 0 monthly premium. So basically it's saying this is a 0 monthly premium for this coverage. But notice what it covers. Covers vision, dental, hearing. But look what it doesn't cover. Transportation. Covers fitness benefits, worldwide emergency. If you're telehealth, it's going to cover that as well. That's been the biggest concern in 2025 as we talk through it, that they're going to start limiting benefits in the transportation world, which generally they have done. Now, that doesn't mean, at a minimum, remember, they have to offer emergency medical services. They don't necessarily, because we're not a part of the essential health benefit. Remember how I talked about that earlier? They technically don't have to cover emergency ambulance service. That is, generally speaking, they don't ever do that, but they technically could if they wanted to try to prove a point. They are going to get rid of some of the non-emergency benefits. Like this place right here, I can almost guarantee you they're not covering non-emergency benefits if you would like this. So if you need a non-emergency transport, you can go to the physician's office, you have a discharge from a hospital, it's going to be a non-covered benefit. If you have that inner facility that I talked about, because some people bill them non-emergency, guess what happens? They're not going to cover that on this plan that if you choose that. But the patient may not even be thinking about that. They're probably looking and saying, oh, I've got cataracts. I'm going to need some vision work done or whatever. That's what's most important to me. This is going to cover it now. I don't have to pay out of pocket. All right. So this is the different types of things. This doesn't include drug coverage. There are some that may cover it, some that may not cover it. Here's another plan that you're looking at. Oh, let me go back. See, you're out of network. Your in network out of pocket, your maximum out of pocket in network is $3,900. Once you get to $3,900, they pay it at 100%. You'll never have that with Medicare Part B. Does that make sense? And so that's 3,900 bucks. Look at Select Health Medicare Program HMO. If somebody decides to choose that, now look at the different benefits it covers. It does cover transportation. So if the Medicare Advantage program looks at this, it's still a 0 premium. A monthly premium that they don't have to pay. It does include some drugs, depending upon what they want. Notice it doesn't have a deductible. So they're not going to be subject to a deductible. This is actually a good Medicare Advantage program. And then it has a $3,900 in-network benefit as well. Now, the one thing that I'm going to talk about is sometimes that in-network can go across anything. So it'd be 3,900 bucks. They could say, you know what, I'm going to cause a 0 out of pocket for your fitness benefits, your hearing benefits, your telehealth, your physician's office appointments. We're fine with that. We're not going to charge you anything or whatever. But yet I'm going to say 250 bucks or 400 bucks for every time you use the ambulance. Okay. They can actually do that. And that's why sometimes you see these different amounts, like thinking, how come it's like they use United Healthcare and now I'm having to charge them 400 bucks for a copay or 350 bucks for a copay. That's why they see that there's some volatility there. So let's kind of talk what the data is telling us now. What does the industry need to pay attention to of what's happening? Right now, what we do know is that 50.5% of all of the 67.5 million lives that are covered under Medicare are currently in the Medicare Advantage program. So basically half of the Advantage individuals are here. This is information updated by CMS as of the end of June. Now, notice that there is about 90% of the 67 and a half that are over 65 years old. There's still 10% of that number. So about 6.7 million people are under the age of 65 that have care. It's going to be more of your disabled patients. Okay. So oftentimes there's people that don't realize that. They use that. They don't get the information. They're like, oh, they're over 65, so they must have Medicare. So I'm going to go look at that. Remember, there's a large number of individuals, and you can actually break this down by state. You can go by Colorado and figure out how many are under the age of 65 in the state of Colorado. I can break it down even further into each of the general areas. So you can kind of get an understanding to know like, oh, this might be a problem in my area. In my area, it's like, there's only 5 people. You know what I'm saying? So that would help you understand, should I have a more egregious, or not egregious, but a more aggressive process on working through some of this. Data is a powerful thing when you look at it. Now, what you do see here is the differences in out-of-pockets. Not all Medicare replacement plans are created equal. That's very, very important to note, depending upon the patient and what they do. In network, generally speaking, if they're in what we call narrow networks, it's in network, there's only an in network, there's not an out of network outside of emergency services. You see where you've got about 15.5 million enrollees in an in maximum out of pocket of $4,800. You have some that will enroll in kind of like a PPO type market. This is basically you can select whichever preferred provider that you want, works similar to your commercial insurance, but you're going to have a difference in the in and out of network out of pocket. Okay, this is going to impact EMS. This is what we see impacts EMS the most, especially with out of network ambulance services, our emergency ambulance services, because you're not contracted. So usually speaking, what will happen is sometimes you're thinking, but how come I'm keeping this out of pocket? It looks like they met their in-network out of pocket. So why are they continuing to subject them to it? Could be the out-of-network supplying because of that. HMOs, of course, there are some different HMOs that they're looking at that are $3,965. That was some of these other ones that we saw, $3,900. You have local, these are local plans. So think about it, usually when we see with this is a very local, regional to a hospital that has decided to get into, it could be a health plan that's decided to get into being a Medicare replacement policy. Very, very local. They have different types of benefits and a local PPO network. So for instance, like in Louisiana, the auctioneer system, they have their own Medicare replacement. Kaiser, think Kaiser. You have to stay within the Kaiser network, the Kaiser affiliate, their Medicare replacement plan. You move outside of it, you don't have many options or whatever. And then you have regional PPOs. This is probably going to be more like companies, I would say like Amerigroup, that does things like that, more regional, think higher out of pockets that you go through this, but there's only about 3 million people that are enrolled in that. Most of the people in the Medicare Advantage are going to be in the first 3 columns. Okay, that's going to be where you're going to really probably focus, and you can actually drill down all the way into to figure out what's happening here. This is the one area that I want to spend a little time on because you have the most questions about, because people have been demonizing because of all the bonuses out there. Like, look at that. Look, I mean, they've got $12.2 billion. So that's literally what the bonus payments were as you work through what the Medicare Advantage programs were doing. And why were they doing it? And it was just some of those benefits that they're sharing. If they were able to stay within a 4-star rating, meaning they had to deliver on certain of the AAA things in the star and the ratings. These are your top that are the 80-20 principle regarding the top 10. Okay, United Healthcare, you can see where they were in their ratings. If you look over to my left, I'm looking, or to your left here. So in 2024, you can see if they were 4 more stars, you see the blue colors. You can see where they were with United Healthcare. And you can just kind of go down the list and see who has the problem. Centene's a big issue right now. And that you kind of work through that piece of it as well. But most of them earned lower quality scores for 2025. That's the reason why they're having a problem with the way the bonuses are. Here is the issue. So they filed a lawsuit. Several of them, United Healthcare, Humana, and filed lawsuits regarding their star ratings. A lot of them actually fixed it. The judge erred in their favor that CMS had a formulary issue and had to come back and pay them and change their bonus payments. Okay, so this is kind of what you will see here in those plans and what they previously were supposed to do and under the current ratings, and then what the lawsuit actually did. And they had to come and set this back up. And this was this stuff that transpired in June. So any of these pieces, with mainly Humana is probably your largest with United. So a lot of you guys are doing this. They change names regarding what's going on with their Part C. Here's the thing that everybody has been focusing on. This little chart right here. As you can see, in 2015, bonus payments were around $3 billion and went to $12.8 billion in 2023. So as it started to escalate right after COVID, in the numbers. It became kind of lucrative business for the private insurance carriers to manage the beneficiaries. There was an influx of moving people from Part B to Part C. You saw the transition started. It really started within the Trump administration. You can see they were really pushing the Medicare Part B beneficiaries into Medicare Part C. Like privatize it, we get out of the business of doing it. It continued on into the Biden administration, and it just continued to exponentially grow. And come 2021, 2022 is where you started to see a lot of discussion around, are we paying bonuses appropriately? The inordinate denials are happening. Providers are complaining. They're not paying their bills. They're denying stuff, no medical necessity. A lot of that stuff started going on. And if you were in those areas that we talked about the data the last time, we talked about the market saturation, that became the problem. And so people are like, I'm losing money on patients. My cash for transport's declining. We can't afford to pay. And a lot of it, people started looking and say, there's something going on, Medicare Part B, Medicare Part C. And so this is what we know they were incentivized for. So they really cared about the 4 and 5-star ratings, which that goes back to some of the stuff that Matt's been talking about. This is all customer service driven. It's very important. You should figure out, especially how can I lock in to help them improve their star ratings? Is there things that I can offer? This is kind of where the community paramedicine, the mobile integrated health process came in. This is why a lot of people started targeting to the Medicare. How can I bring value to you? People started talking about really understanding what the star ratings do. And so some individuals have been very successful and have really been able to start tying the benefit of the value to say, if I do this, this is how it can improve your star health rating. That can also improve your bonus payment. The problem now is when the bonus payments were lucrative, that worked. Now what happens? And this is what we're all paying attention to over the next quarter because they just went live October the 15th with the 2025 Medicare Part C enrollment. Benefits have changed. Bonus payments have changed. The Advantage programs are really hitting the hill. You have seen them hire on senior executives that used to either work for CMS, have worked for others. The health plans are now hiring them. And so it's a very interesting thing what we're beginning to see as a shift. So that tells you they are priming. We know they're on the hill. We know they're talking that this is going to be a major issue. They know Medicare wants to move things, but they also want to know, when do we level set? When do we level set? What's that sweet point that says this is appropriate to be paying out $11.8 billion this year? So first time it's decreased. And of course, they're all screaming, there's not enough money. We're going to have to we're going to have to change benefits. And so some of the benefit changes are going to be strategic, political. So there's a reason why they're going to take away transportation from people, because if they take away transportation, patients can't get to their doctors. What happens? You know what I'm saying? So it's kind of people thinking, well, why are we touching transportation? We are kind of a political hot pocket when it comes around to it. If you provide air, that's a nice little political window if you do it. People like that. If you're 911 and you're fire and you're in your uniform, people like that. So think about if legislators like that, then you're going to see payers are going to use that to their benefit right now. And they're going to say, well, we'll just take that benefit away. And so then they're going to go screaming. So now we're going to get engaged the transportation community. They're going to go screaming and saying, well, if the patients don't get here, then they're going to wind up in the ED. Now we're going to surge the ED. This is what happens. And so that's actually what you are hearing right now. That's what you're beginning to see. That's why you're seeing all the articles. There was a latest article that just happened in Forbes about 6 days ago that kind of started talking about that. What does that look like? Where's CMS on that? When are they going to address that? There's been a lot of happening on the Hill in the Four Corners, which that means that would be the Senate leadership and the House leadership on both the majority and the minority side. They have been canvassing, trying to figure that out. Here is what's very interesting to me that we should pay attention to. And this to me is the best data that providers should pay attention to. Notice, and this is the big issue that has started this whole concept, where there's been a majority of claims that they are inordinately denying for no medical necessity. The air ambulance industry has really been hit with this hard. They are really denying a ton of claims for prior authorization. Even though some stuff they actually even can't deny for prior authorization, they have been still doing it. But look at the numbers as they've increased from 2020 to 2021, and they went from 36.5 million to 46.2 million in denials. Notice that they denied a larger portion of prior auth requests in 20 than in prior years. Look how much they increased on just the prior authorization side. And I'm using this from a reason, not just prior auth, but think no medical necessity, think other denials as you're going through this, because notice this, only 1 in 10 denied were ever appealed. That's very key for providers. They did not appeal this. And when they appealed, when the provider appealed, that 1 in 10 that appealed, 80% were overturned. And this is why the data is telling them the insurers are playing games. So think about it. If you have a Medicare Advantage program, they denied it for no medical necessity, forget the prior law, denied for no medical necessity, and you didn't appeal it. I bet the stats are going to look a little bit like this. Right now, there's a big issue to reverse prior authorization. So that's why they're pushing out all the data related to prior auth. They want to fix it, get rid of the prior auth for the most part. But the same thing applies to no medical necessity. We see a lot of that specifically even on the 911 side. If you're transporting patients, think about that ICD-10 codes that we showed. Maybe you used the wrong ICD-10 code that denied it no medical necessity. You didn't go through the appeals process because a lot of them you're not contracted with. They indicated, well, if you do appeal and you lose, you got to sign this waiver to do that. And people just stop doing it. Instead of getting the patient to submit the claim, you bypass that and you do it for them. And so what happens is 80% are getting overturned. We see that right now. If you appeal, very, very large portion is overturned in Medicare Advantage because they're playing games. Some of it is our fault. Maybe we use the wrong code, but sometimes it's just an edit that they have in the system. So this, I expect, is absolutely going to change. Congress wants to change this. And so this is a big fight that you can't take away our ability to pan this. Now you're shrinking our bonuses. You can't take away our ability. You remove almost all of our abilities. We have to have essential health benefit plans. I can't charge somebody for emergency services more than I would be able to if they were under the Part B plan, except for us, guys. I'm going to talk about that in a little bit. But these are different things that our industry has to do as well. We kind of work through it. So the providers are part to blame for this. When you're getting denials for prior auths and only 1 in 10 appealed it, and there's an 80% overturn rate. So that just tells me if you're not appealing it, then you must agree with it. Or maybe you have so much cash on hand, you don't need to worry about that. Because that would be when we all laugh when we talk about that, but I'm like thinking, then why aren't you feeling it if you don't have? I mean, it's kind of funny when we're talking about this emergency physicians, for instance. I was at a emergency physician conference and they were talking about, and one of the third largest emergency physicians, they decided, we're not going to appeal all this balance billing that we're under because it's costing us more to do that. So if they pay us this much, then we're just going to accept it. And it was like, okay, so you proved them right in passing the No Surprises Act that you were literally making so much money that you were able to do that. Do you see what I'm saying? It was like, duh, like you've got to fight. It's the truth. If it's not the truth, then you've proved their point. But if you don't do it, it's the same thing that I say here. If you can't hold your hand out for more money, a denial is happening, but you're not doing it. Okay. And so I'm passionate about the reimbursement side. That's what we do because I see it. Why are you writing that off? Well, we don't have time to go back and do that. Well, okay. I guess you have a lot of money. Well, no, we need more money. Well, okay. Well, maybe you'll go to the tax and get a tax subsidy then. Maybe they'll pay you more. Okay, I'm picking on my friend Rob from Austin Travis County. Maybe you just have lots of money like you do in Austin. You're just gonna get lots of money. They don't really pay us attention to their money piece of it. So what are we supposed to do going forward? That's the big steps. What are we working on to injury? To me, this is the lowest hanging fruit of anything that our industry can do. This is all regulatory wise. I'm skeptical why it hasn't been done because I do think they like this piece of us being kind of there. But number one is know the 2025 coverages that are going to be happening in your area. There's a lot of coverage changes, guys. So if you're operating in Denver, Colorado Springs, definitely pay attention to any city where you have more than 100,000 residents. You probably have a more inordinate number of Part C. So know which coverages It could be the same plan, but they have different coverages this year. And they may at one time have covered ambulance and now they don't cover it for you. They may have at one time been paying you with no out of pocket, and now you're going to be hit with $100 in a pocket that you're going to be billing the patient. And if you have in some jurisdictions or some areas where maybe you don't bill for copays to the patient, that's going to be impactful for you. If they went from 0 to now 100, you just lost $100 on your transport. Okay, so I would definitely make things. I sent you that little. You can go in there and figure that out yourself. You can go in there and go and figure out which are your big plans. Go run a report. See, all my top 10 Medicare plans are these here. Go plug in, find it in. You'll have all their coverages. It'll tell you what their out pockets are, what have you. It's a really good resource guide for you to understand, is there going to be an impact to me? Analyze the data for the outstanding impact. That's what you're going to do there. Prior authorization, if you do interfacility transfers, non-emergencies, anything like that, pay attention to what happens in PANS. Find out how many they're denying. Are you appealing them? The data shows that pretty much 80% of your appeals, you probably will get paid if you just appeal them. All right. If you're doing repetitive patients, this is really only for non-emergency piece of it. Understand your maximum out of pockets and manage those. We have a lot of people doing some really great work last year that were holding their claims until they got to their maximum out of pocket, and then they billed it and they would get paid 100%. It's amazing. And they were usually average holding them anywhere from 85 days to about 96 days. And that 85 to 96 days window is saying, well, they had a $250 copay, which we knew. I was going to get a $50 payment. I'm going to hold it for 90 days. Now I got a $350 payment. Okay. So there's different ways to kind of game this. If you ever pay, and this could even be those frequent flyers that call you on 911, you kind of look and see, I'm going to hold them and I'm just going to wait until they get it, because you can usually use that. There's automated solutions you can do. You can do it manually. If you want to use an automated solution, we provide that service as well. So we can tell you, they've met it. It's in the claim. So it's pretty interesting what happens. Usually we see 85 to about 96 days is kind of what you hold that for. Almost kind of similar to what with deductible. Here are the future reforms that we're looking at. One is the prior authorization process, of course. Getting rid of that. There's a whole way we're jumping on that bandwagon, just like the physicians are doing things like that. Really, any prior auth that you would be doing in non-emergency really should be out the door. That should be really easy. There's already a way to work that piece through. The second thing that's the most impactful to everybody in this room is emergency medical service. The inclusion of emergency medical services currently within the definition of the Part B and Part C reg. So currently, if you are an emergency medical services provider, you cannot have an out-of-pocket greater than the out-of-pocket would have been in a Part B Medicare beneficiary. So for instance, if you had Medicare Part B and your out of pocket would have been $50 for a transport that went 6 miles. If you elected to have United Healthcare Medicare Advantage, they could not have a copay more than $50. The reason why we see that as an industry is we are not in that definition. And the insurers saw that because they knew that was a limitation. And so they're able to transfer it over. And that's a problem. That's why. If we can get it included, it makes sense. Most people don't realize when you start, are you kidding me? What do you mean y'all aren't in it? And then they technically go back and look, and we technically are not in it. The insurance carriers that found that loophole as they're trying to manage their patients so they can make more bonus monies, get higher star ratings, show whatever. And that's what they've done. So they've sacrificed and given the people the 0. And to us, it's just like a no-brainer. Of course, we're emergency services. But it's the same thing that I go back to in COVID. When we couldn't get the PPE, we didn't realize that we were not an essential service provider as or whatever. It's the same concept. I think our eyes are being opened now, like things that we just assumed, we've got to get changed here as well. This actually is a regulatory issue. They realize it. They've known about it for 11, 12 months now. We still don't have a rule on it. Okay. They should fix this. This is a huge benefit to the industry. If you all of a sudden went from $250 copay now just the normal Part B, you're not going to see a big difference. So that's why we don't see the emergency physicians. To them, it's like, we're fine. Like when we look at Part B to Part C, our average out of pockets are around the same. They're usually $1, $2 variance. When we look at anesthesiology, same concept. But when you look at ambulance, Part B's down here, if you let Part C. So it's like, that's why we tell people don't let Part C. I tell people to be careful about that because I think you might have a risk and liability of informing the patients that you serve not to select Part C. I wouldn't do that. I would strongly advocate that you don't do that because you are not certified advocates that do that. I would strongly suggest you don't do that. I know why you're doing it, but you're doing it through the lens of ambulance, and you could have some risk there. Understanding because they might be choosing it for a different reason. This is where we should fight. Get this definition changed. Make sure we get included in there. I'm also suggesting that we expand the coverage requirements for Part B. So it's not so lucrative for them to go to Part C. To me, that is, while we're advocating, we might as well ask for it. I wouldn't lose any sleep that we'll ever get that. But it would be something that we should ask for. Ambulance response, no transport, I do think will be expanded in Part B. I talked about that earlier. There's a general propensity by CMS to understand it, get it done. The data actually is very indicative that it's not a really big problem to it because I'm concerned if they don't expand it in Part B, if they don't address these bonus payments, we're going to see some stuff and wins that we've had, for instance, with the anthems with the Humanas paying for ambulance responses. Some of the stuff that they've been playing around the treatment in place could go away. And so we're starting to see that in some of the new design for 2025. So some of the ambulance industry that has been getting paid for some of these value added services could be going away. And that has been the biggest concern. And we could see that could be like a political pawn. So if you're dealing with a lot of payers right now, I'd be asking them if I have contracts with Humana right now, I'm asking it, going to the table to them and finding out, hey, you saw the value add in the community. We service a lot of your beneficiaries in this community. Are you cutting any benefits in 2025 based upon the new star ratings, the new bonus payments? You should be having those conversations now. We're watching to see what Anthem does with their coverage that they came out with. If you're Anthem Blue Cross Blue Shield, they do cover a lot of ambulance response and transport in a selected environment. We're watching that. This was a value add that they offered specifically in the Medicare Advantage piece as well. So that's a little bit of what I wanted to talk about quickly for you. We're going to give you guys some time back through this process, but to see and understand when we're talking about Medicare Advantage, what's happening, 2025 is going to be a very interesting year for Medicare Advantage in the ambulance space. So we're watching the data to tell us what that is. You are going to be impacted. If we can't get changes from the Part B to the Part C, understanding the out-of-pocket rates, we do expect that to be a problem. Whether you're an emergency provider, if you're a non-emergency provider, I think you're going to be inordinately impacted because we're seeing a lot of plans cease paying for non-emergency side of it. If you're under contract, if you're not under contract, we have an argument to be made. They could subject you to a prior authorization. They're not prohibited from doing that for coverage, but then you're going to want to change and make sure that you're appealing those prior authorization as well. And a lot of people aren't doing it to the process. It can be a little bit more administratively burdensome too. So I'll stop here and see if y'all have any questions. It's like glazed over. All you're hearing right now and all we're hearing right now is we really honestly don't know. We know it's a problem and we're going to start following the data. It's what I do like that we've gone to as an industry. We're now at the data phase. We're paying attention to coverages. We're getting much more granularly into not just looking at things from Medicaid, we're looking at it from Medicare now. We're looking at a Medicare Advantage. And we're also going to start paying attention to what money are we leaving on the table because we're just allowing the denial to stand. And we're billing the patient, thinking let's just get the patient involved. Because of all the consumer friendly protections, that's going to be an issue. And I can't imagine that Colorado is behind when it comes to consumer protection. So it'll be interesting to see what you guys do here in the state of Colorado over time, or what the patient advocates do. You may not do anything, but the patient advocates will do it too, as well. So this is another area to pay attention to because with the shift, I will tell you this last thing. CMS is anticipating that they believe 7% of the Medicare beneficiaries that are in Part C right now are going to shift back to Part B. And the ambulance industry would be very happy. So depending upon where you are in the large urban markets, that actually could be a very great shift. And so if that transpires, we're going to watch that number. Does it go from 50.5 to 45.6? That's actually a win for the ambulance industry. Maybe not for the payers and maybe not for some of the hospitals or whatever that has some ancillary benefits that we're getting paid for, maybe the vision and the dental and the people like that. They don't like it, but the ambulance providers, some of us will probably say, yeah, great, we're glad that happened. But that's going to be sporadic. So you could see, Denver may be happy because they shifted, but Colorado Springs saw an increase in Medicare replacement. Kind of like, oh, we don't like that, right? I'm gonna make it to that airport on time.
I'm gonna throw a question out here. I mean, this just kind of just, holy crap, why is this so convoluted? We provide a needed service. Why, I mean, it's the obvious question. Why is it not just paid?
So I'll tell you this. That's a that's a good question, and depending upon where you are in EMS, depends on how to respond to this. So I don't advocate one position over the other. The only way you're going to get paid for everything that you do is going to be through more of kind of like a utility model. That's the way it's going to work. So Medicare can only pay you if they have a payer. The problem is we have a very large uninsured market, or underinsured market that we serve. And there is no mechanisms that we have outside of the stuff that we've done for the last 20 years. And unfortunately, like the GMT program, that was supposed to help fill some of those shortfalls. But then we have issues where, okay, then you're doing this. And so it makes you look at what are you doing through the process. If you're a for-profit entity, a lot of that we were trying to fill those gaps with Medicaid financing programs as well. You're seeing a proliferation of that as well. Still doesn't fill all the gaps. And so the insurers were filling that gap. They don't want to do it anymore. And so I agree with them or not, they should pay for it. You have all these bonuses, and I hear all the arguments all day long. And I'm like, great, we've been saying these arguments. I've been saying them for 16 years. I've been advocating for it, and we still haven't won anything. So to me, I'm like, the reality of it is that we have to look at our organizational side. So in order for me to get paid for everything, this came out in a very interesting presentation, and has been something that's been going on for whatever, but our own industry has a different idea. So for instance, Pinellas County brought up, if you were listening to something where they kind of talked about, you know what, we're guaranteed Medicare on every single transport. Now that was Pinellas County. And they're like, we're fine with that. We can provide a great service in Pinellas County, Florida, as long as I'm guaranteed that I can make Medicare on every single transport. Okay. Now, some people would say, I was asking last night to say like, well, if Medicare pays, oh, well, no, we'd go under for if it was Medicare on, even if I got Medicare in every single transport, you're whatever. So it's going to be different from each area. Hence the reason why you have to think of it. Does a utility model work? Kind of similar to why they keep asking, how do they do that with water? How do they do that with electricity? And some of us can't put our mind. And to me, I think we probably should shift because it might be advantageous to the industry of 911, regardless if you're a fire system, a county only system, you're a third service system, you're a nonprofit, or you're a for profit. A kind of utility model might be the way that works. Now, what do we do in the IFT space or in the non-emergency space? I'll tell you, generally speaking, they think the free markets prevail there. And data shows that. And literally, so you can go and you can see the data will show it. Now, we don't like to talk about that in the industry, but once the information becomes a little more transparent, it's going to be very, very obvious that you're sitting in a room probably with people that are negotiating stuff that you have no clue about. And they're doing it. And so Congress people know that, senators know that. And so generally speaking, I will tell you the health insurance plans think that, people in our own industry believe that, some don't, but some people do. The academics believe that, the people that study that the free market will dictate the non-emergency. So that's kind of why we were able to not make a recommendation on non-emergency, leave it over here, that the free markets. There are certain areas that they probably will have to address it. It's going to be more in the areas where it's locked down. So for instance, Matt was talking about MedStar. It's a lockdown market. They do all emergency and non-emergency. So theoretically, but they've got a board oversight. It governs the rate, supposedly. We do know that there's probably, I'm not saying this is MedStar, but there are some times that we say we're locally regulated and it's really just, I have a really good shape. You're the mayor. Here's our rate. Can you sign off on that? And not the mayor. You know what I'm saying? So some of that politics, so you'd have to have safeguards around it. We can do that. In my opinion, that's the way to fix it. But the utility model is something that people are going to have to, it is getting more and more oxygen, just so you know, a lot of oxygen. I fully expect it to show up in the MedPAC report. MedPAC commissioners are understanding it. Some of the CMS folks, I was on the phone this morning before I came here, same thing. Just tell us about, I need to spend a day and just really understand how that public utility model works. And it's like, what are the do's and the don'ts? And so we have people in the industry that think these are high impact systems. We have them out there. Doesn't mean that they work for everyone, but could it work in an environment here that would say, hey, if I get paid for everything, maybe I'll lock in at a lower rate. Transparency is going to reveal, because then generally speaking, on the governmental side, it's going to be a little different. Governments don't really look at margins like profit margins. Nonprofits do, and for-profits do. So that's going to be an interesting marriage of the discussions that work through that. Too. But that's to answer your question about why can't you just get paid for everything? That will not happen. I don't think I will see that. I was going to say in my lifetime, but that's not true. I think we're going to see something, but I think 911 is steering that way, steering your own way there. Your arguments that you keep giving to people are kind of steering you to that model, whether you think it, whether you realize it or not. I usually tell people, what is the data not telling you? Look at what the data is not telling you. Take your arguments that you're using, and is the data supporting your argument? Are you steering people a certain way? And to me, I can't believe we're even talking about the utility model. Do you know what I'm saying? Like, it was faux pas 6, 7, 8 years ago. Some of you kind of know that here in the room. Now it's like people are talking, they're actually kind of getting comfortable with it. And I'm having conversation like thinking, I don't really know if this is a bad idea. I'm like, probably isn't if it's structured correctly. The problem is the unknown is, well, what if they don't structure it correctly? I mean, it's not going to be the Fed. So there are certain things that were in the MedPAC, the gap back report and the finding. You'll see there was a finding that asked for a standing committee that advised Congress and CMS on any changes. This happens already in other fields. CDC has standing committees that make recommendations. But this might be something that constantly meets versus us having to go advocate, ask the Congress to do it. We can get it. It is an automatic. And so whenever there's some new innovative thing that we want done, this blood thing, for instance, happened. Well, this kind of happened in a pocket of stuff and people got involved in it and people came through and then all of a sudden, I didn't even know what was going on, to be honest with you, until I got a phone call from CMS that said, tell me what this blood is and tell me what the impact is for ALS2 on this. I'm like, what are you talking about? Well, we've been meeting with these people and they're saying that we can upgrade it to an ALS2. And I'm like, if they're giving blood, I bet you $100 already. It's already qualifying for ALS2. So it's to me, I don't think there's a reimbursement, and that's an additional reimbursement there. And that was the thing, that the thing was that we thought, oh, if we get it recognized, we're going to get more money. And I'm like, somebody had to do the due diligence. And so CMS let it go through because they're like, no, we already got, that's what we came back with, that we think that it's actually going to be a savings in money because the people that qualify for SCT now can only bill it as ALS2. And so we think there could be a savings to the program. Now, if you do a lot of SCT, and that was the reason why you were doing blood, you're going to need on the initiative. But if you're the provider that may have been doing ALS and you did blood and you got to ALS2, it's an additional reimbursement for you. But probably if you're giving blood, it was already some multi-trauma event anyway, you were doing some other condition that already qualified for the ALS2. And so this is kind of where we have got to, if we have a standing committee with people that really understand reimbursement, they can bring this out. So then you would have made an additional request for something saying, hey, let's do this. And it gets you to the outcome to get that additional money. Does that make sense? So to me, when I looked at that and that was put out in the rule, it's a win. It recognized that we need to have additional ancillaries. that is kind of why I tell myself a narrative to make myself feel good that at least they're recognizing it, but it really didn't bring any more money into our industry. That makes sense. Right. Long way to answer your question, Kim.
All right, any other questions for Asbel?
Asbel, do you think we're actually catching the inter-facility transport data? Because, I mean, it seems anecdotally amongst us in the hinterlands that the healthcare systems are more and more centralized. The smaller hospitals are hanging on to no one. And even in the big systems, they're moving them from one place to another. What appears to be more often than we seem to remember. And I just wonder, is the IFT data getting lost? Because generally it gets coded as an emergency something, if it's unscheduled. And a lot of these are we?
So the data is being captured by the modifiers. Okay. So generally speaking, the interfacility H to H modifier is going to capture the interfacility. And you can go down to the region, you can go down to the zip code. More importantly to the question that you're asking, because I think that's really important, is hospitals have created these affiliated systems. And there's a lot more transfers happening because of that. So they become specialized in their market, where they used to have the same specialty used to be in all the hospitals. So they would offer cardiac and stroke or whatever. But now this one does cardiac, and you got to transfer it. If there's stroke and somebody comes in, I'm going to transfer them out over here. Now, generally speaking, they're like, well, wait a minute. EMS is supposed to take them to the closest hospital that can appropriately treat them. So if they knew they were having a stroke, why are they taking them to to I'm just gonna what's your UC? Is it UC Health?
Well, we have a dinky little critical access hospital in the middle of nowhere, which takes care of nothing.
Yeah, which technically speaking, the way the rules are written, they would supposed to take them to not your place that couldn't take care of them to the place that could take. Technically, that's what the rules state. We have bypassed that. It's kind of an arcane rule that needs to happen, but generally speaking, you're supposed to take them to the nearest appropriate facility. And this has been the biggest issue with their facility. How do we manage it? What do we look at? What do we do? The affiliated system is going to become very, very big here shortly, and the insurance carriers are going to demand a different piece, and you're going to kind of work through the hospital. This is why I think a lot of people are talking about even inside CMS, should the hospitals just take care of and govern interfacility? Doesn't mean it moves the EMS out of the market. Doesn't mean the hospitals come into the market. You just become a subcontractor to the hospital now. That's what I see is going to start happening. The affiliated hospital systems is going to cause that.
So they're absolutely agree. So for instance, UCL. So Parkview in Pueblo's level 3. They could handle, the only reason they're not level 2 is they don't have 24/7, 365 neurology, neurosurgeon, that type of thing. So now UC Health is bought or now partnering with Parkview. So ultimately what's happening is our hospital, little critical access hospital that is keeping things, is now saying that Parkview will not take trauma admits for in facilities. So now we're going from a 3-hour turnaround for an facility to a 6-hour turnaround in a facility, and bypassing, not only do they do that, they bypass another level 3. It has somewhat limited, less procedural things, but we worry, like you said, we've always been taught, take them to the closest appropriate facility. And now, then once that one hospital fills up, then we take them to the next UC hospital. That's another half an hour, 45 minutes down.
So generally speaking, I'm going to give you guys a very general comment to your comment. We do know that some of the regulations are outdated, and you need to make sure you can justify why you're doing what you're doing. And I'm saying this for a reason. So it doesn't mean that you're not going to have to appeal it. You talk to the attorney, they're going to scare you to death. Don't do that. I mean, I'm going to give you a few examples of why I'm saying what I'm going to say. If you take a patient in and they indicate this is the nearest appropriate facility, and you've done a due diligence, whether it was through a screening in your dispatch, you were talking to the critical access, how they don't have a screening, doesn't matter whether they did or not. I went through my due diligence, take them to where they're supposed to go and bill it the entire way there. And if you get audited, you will win the argument if you can crack that thing through the process. And the only reason why I'm saying this is done it with numerous audits before. The latest trajectory that we had where we were being, not that we weren't being informed correctly, because attorneys have to tell you one thing because they have a responsibility based upon their certification. I'm not an attorney, so I'm looking at it from the risk standpoint. And can I win? And does it make sense? This is the COVID transporters. So we had the first audit happen about a year ago on COVID patients. And so to me, there was a lot of isolation needed to happen. They were not sending patients out. They needed to go by something. And so most people were saying, well, they can walk and sit on the ambulance bench sheet. Why? Does this meet medical necessity? And I'm like, number one is it's isolation precaution. They need oversight. They don't want them jumping out. And so we didn't know what was going on with COVID at the time. We got audited. This provider wound up getting extrapolated. They wanted $7.75 million back. About 3 weeks ago, I'm actually going to do an interview with them. They want to go on. I'm going to talk people through this process. They overturned every single one of them in favor of medical necessity, that they should have gone that route. And so they went from having to owe almost $750,000 to $500 because it was a technical thing they come on because they didn't get the signature to be able to bill Medicare. You know what I'm saying? So it had nothing to do with the rate of that piece of it. It came out to be, it was a more of a technical thing where they didn't get that piece of it that you overturn. So my standpoint is if you're doing the right thing, you're following the right law, they don't expect you to go to every hospital and say, do you have a bed? Do you have a bed? Do you have to do this? My issue that we're more concerned about is I'm not worried about that. That regulatory piece will get fixed. I think that's where that 2013 MedPAC, I think you're going to see the same articulation to Congress that's going to say you need to promulgate rules to be more specific from a clinical perspective. We need to be very clear on what constitutes emergency versus non-emergency. They need to fix that piece of it. The affiliated hospital system is going to become an issue. It's going to become a major issue in the industry. And that means we're going to become subcontractor. It's going to be the either the hospital is going to be responsible for it. The SNF could change. If you do SNF transfer, remember SNF consolidated billing started that. We pushed back on it in 2009 and we were able to get some carve outs. But it's hard to deal with all these home health providers, all these EMS providers to keep paying. It's like, let's move it under one area that can control the piece of it. The affiliated hospital system is the biggest issue that the Blues, United, and then want to fix, just so you know. And so they're going to fix it through their contract negotiations with the hospitals. So we're already starting to see that. And so the Blues are the kind of the first to go, kind of testing it out. And so I would be paying attention to the way my contracts. So if I don't have contracts with them, then you can bill your bill charge and see how you get paid. But hospitals have a lot of political power in regions and in different areas as well, where if you try to say, well, no, you can pay my local regulated rate, they may get with the mayor and county and say, let's figure this out. Like we can't pay this type of rate for a service in the affiliated system. So I think that's the area inter-facility you're going to have to pay attention to if you're doing that work, Sean. Long distance, I understand is an issue here, and there's somebody I want to help with. I want to help with that. Like we're going to get that fixed on the behavioral side.
So the other thing is, so if we do not bill Medicare, can we just send the bill to the hospital? And is there anybody doing that?
What do you mean you don't bill Medicare? Are you
No, what I'm saying is, so.
Are you participating in Medicare?
No, so we wouldn't send the bill to Medicare. We're just gonna send the bill to our critical access hospital.
So here's my standpoint. If you have a contract with a critical access hospital that they just pay for everything, you're not violating anti-kickback. You don't have to bill anything. You make sure your contract's really specific. This is what we bill you for every transport. There's actually ambulances. That's what they do. They refuse to bill. They're a sole proprietor. That's all they do. And so they don't fill with billing. They don't do anything.
They ain't gonna sign it.
You can do them as payers of last resort. There's different nuances that you can do so you don't violate the anti-kickback statute. You're not going to really do it in an area where you're the only provider, just so you know. So there's going to be some different nuances, but you're seeing a lot more payer of last resorts. We used to do that a lot as an industry, and it's becoming more popular. I think, it's becoming much more popular.
How are you going to help us fast long distance IMTs?
So here's kind of the thing that he was telling me about on the long distance IFT was really related to the behavioral. You guys have an edit in here that if they hit a certain edit, I don't think you realize what it is yet, but if once we know what that edit is, if it's 150 miles, 145, 150, 170, but if you guys have a behavioral health where you're having to move people and they're having to go long distances more for behavior and it's on the behavioral health side, I will tell you CMS is really looking to fix this issue. And this is one area that really hasn't come up. A lot of us that are dialoguing, how can EMS be involved in this? What do you need to do with that? In my opinion, you can't use these secure patient delivery vehicles or police, fire. There's a lot of nuances they need to fix just around that. But the edit needs to be turned off. It can't be a global edit. That's the issue that we have with this. They gave a mandate to the CMS to say put edits in place because the OIG uncovered that the industry was billing for a lot of transports that were kind of convenient and over. They really found this in the Massachusetts area because there's so many level 1 hospitals. It was like, why would you ever bill for a transfer that's more than 40 miles? Okay, so like there they have a claims edit that locks them in. You try to do more than 48 hours, you're going to have to prove why you need to go more than 48 hours in Boston. You've got some of the major medical centers there. Does that make sense? Same thing in Houston. You shouldn't need to go that far. But how do we, you can't put edits in place for the entire state. You might have an edit for Denver, and you might have an edit for all other localities in Durango. But if you've got this issue, specifically behavioral health, so they should ping and work something like that. They've done this some other thing, but usually it's kind of Mac centric. And if it's happening here, it's almost like they need to give a like push out kind of a notice, not a rule, but kind of just a informative bulletin to the max saying you need to make sure and go through your edits that we asked you to put into place to make sure you have the appropriate edit. But if they're denying every single one of your claims, that's kind of ridiculous.
They're denying all the mileage.
Yeah, all the which that's probably the majority of your bill, and especially if you're going that long.